Welcome everybody. I'm just going to let everybody in. I think we've got a very large audience today, so welcome. And I think we'll get underway because we've got a lovely topic to get through today and we need the time. So welcome everyone and thank you for joining us. It's my pleasure to introduce Dr. Andrew Lingwood, occupational physician with OccPhyz Consulting. Dr. Lingwood brings extensive expertise in occupational medicine and has a strong interest in emerging clinical issues affecting workplace health. Today, he will be presenting our webinar, The Update on Medicinal Cannabis, providing current insights relevant to medical workplace and regulatory contents. Just before we begin, just a few housekeeping notes. Please submit any questions you have through the Q&A box. We will address these questions at the end of the session, time permitting. Any questions that we don't get to, Dr. Lingwood and I will get those answers out to you if you've attended today. A recording of today's webinar will be available via our website in approximately 72 hours. And again, thank you for joining us, and I will now hand over to Dr. Lingwood.
Thank you, Karen, and good afternoon, everyone. Thank you very much for giving up your lunch break. My name is Dr. Andrew Lingwood, and I'm an OCC physician here at OccPhyz Consulting, and planning to have a bit of a chat today about medicinal cannabis and a bit sort of specifically with respect to some implications for workplace health and safety in Queensland. It's a bit of a specific topic. I think there may be some people from other states online, so there might be some sort of legislative and other issues that aren't specifically correct in your other jurisdictions, which I apologise for, but there are some differences between states here, and I'm going to be focusing a little bit on the Queensland experience. So what we're sort of going to try and talk about today, break down into a few bits. Very big topic, can't go into detail on everything, of course, but going to try and focus a little bit more on practical matters related to the workplace, also address some common concerns. So I'm going to start by talking about what exactly we mean when we refer to medicinal cannabis, talk a little bit about some of the types and components of these preparations, talk a little bit about some of the common conditions that it might be prescribed for, very briefly talk about where there is actually good evidence for its use and where there's not good evidence. Not going to spend a lot of time on that sort of, reviewing clinical trials and stuff, but just talk about that briefly, and then try and talk a little bit about just issues in the legal framework and then some of these particular challenges in workplace health and safety that are listed up there. So, this, like medicinal cannabis, it's no longer a fringe or emerging issue. It is very, very much mainstream, particularly in Queensland. Queensland has pretty much the highest uptake of the use of medicinal cannabis in Australia. Queensland prescribers account for about 45% of the most common pathway of prescription for medicinal cannabis. That's called the SASB pathway, which we'll talk really briefly about in a minute. But Queensland prescribes a lot of it. It's also been growing hugely nationwide. That very simplified little bar chart I've got there suggests, we've gone from something like about 20,000 to about 600,000 prescriptions over that period of time. When I was sort of reviewing this again today, however, when you look at some data actually from the TGA, the suggestion here is more like that about 18,000 patients in about 2019 up to more than about 1 million patients, or 1 million prescriptions anyway, coming up to 2024. So as I said, this is a huge, huge thing at the moment. So taking a brief step back, what is cannabis? Not going to spend a lot of time on this, but cannabis, it's a drug. It comes from a variety of hemp plants. It's what we would broadly class as a depressant drug in that it typically slows central nervous system activity. Higher doses, it can result in the hallucinogenic effects of the high. It does have a bunch of other effects as well, but it does typically get classed as a depressant drug. So recreational users, they might smoke it, ingest it, vaporize it, typically do so to get relaxation, euphoria, excitement, altered perception. It does also tend to cause increased appetite and a dry mouth as well. At higher doses, you get those less pleasant effects, cognitive impacts, paranoia, anxiety as well. But that's, essentially what cannabis is. And chemically speaking, there's a whole bunch of chemicals in the cannabis plant that produce these effects, and we call these cannabinoids. Technically, we're going to call them phytocannabinoids because they're cannabinoids which come from plants, and there are other types of cannabinoids as well. The most important two cannabinoids from the perspective of medicinal cannabis are tetrahydrocannabinol, which I'll just call THC from now on, and cannabidiol or CBD. THC, my apologies, is the major psychoactive component, the one that's responsible for the high. CBD typically gets called like a non-psychoactive agent. It's certainly true that it doesn't result in the high or the intoxicating effects. It does still affect the brain. So, I mean, whether we should use the phrase psychoactive or not is a little bit of debate. But importantly, THC causes the high, CBD doesn't. There's heaps of other cannabinoids as well, but we don't really need to worry about that for our purposes. Now, the reason I drew this distinction of calling these substances phytocannabinoids is that the human body actually produces its own cannabinoids as well. And it's got its own system of these chemicals or cannabinoids. It's got receptors and enzymes which break them down. And this whole thing we call the endocannabinoid system. So the body produces its own cannabinoids. We call these endocannabinoids. These interact with receptors in the brain and other parts of the body, and they can result in a variety of physiological effects. For some reason, I can see this picture hasn't copied very sharply. My apologies about that. But you can sort of just see up there, again, this is not like meant to be a pharmacology lecture or anything, but the point that I'm trying to make here is that the endocannabinoid system in the body affects a wide variety of physiological processes. It's important for sleep, for mood, for appetite, stress, maybe immune response as well. Now, it is, of course, not the only system of chemicals or hormones in the body that impacts these functions, but it plays a role in all of these. So for these body's internal or endocannabinoids to exert their effects, they attach to receptors in the target tissues, which switch on to produce those effects. You can see up there, there's talk about two types of cannabinoid receptors, CB1 and CB2. Again, we're really kind of getting more into pharmacology here, which is not the focus of today's talk, but speaking very broadly, the CB1s are mainly found in the brain and the central nervous system. The CBD receptors, sorry, CBD2 receptors, sorry, I said CBD2, it's just the CB2 receptors are mainly in the peripheral nerve system and immune system as well. But again, I don't really want to spend a lot of time on that. I just sort of essentially wanted to draw everyone's attention to the fact that the body's got its own system, and it's this system on which external cannabinoids, so the ones that we would take from either medicinal or recreational cannabis for that matter, that's how they exert their effects. Okay, so what about medicinal cannabis? What exactly is medicinal cannabis? So this refers to products which are derived from cannabis plants used for a therapeutic purpose. Now, the definition doesn't mean recreational cannabis bought on the street corner that I've decided to help me with my sleep or my back pain or whatever. That's not what we're talking about when we're talking about medicinal cannabis here. Although there's really not that much distinction, pharmacologically, what's happening here. It is also not the same thing as synthetic cannabis. That's another thing you may well have heard of if you've sort of been involved in drug testing and drug testing programs. There are also a bunch of chemicals which are unrelated structurally to the actual cannabinoids in the plants, but they're chemically designed to activate the same types of receptors. And were essentially designed to get around drug testing. They go by a bunch of names, like I've listed up there: Spice, Chronic, K2, Chaos, various other things there as well. Their chemical structure gets changed frequently just to get around laws attempting to ban them. But again, we're not really talking about these from the perspective of medicinal cannabis. Now, medicinal cannabis products do require special approval to be prescribed. And the reason for that is they are not actually registered or tested medications on the Australian Register of Therapeutic Goods. There are a couple of exceptions to that. There are a couple of preparations of medicinal cannabis which have sort of been around for longer than the sort of more recent spate of medicinal cannabis, which have particular reasons for being prescribed. But the vast bulk of the medicinal cannabis that is prescribed now is essentially, an untested medication which requires special permission, if you like, or special pathways to be prescribed. So it's important to note these medications, they haven't gone through the same degree of testing or regulatory review that other TGA and PBS medications have. So doctors have to apply to be able to prescribe these medications, and there's a couple of ways that they might be prescribed. You can be an authorized prescriber where you apply and you're granted permission to prescribe uh, medicinal cannabis, for example, to multiple patients with a particular medical condition that you and as a doctor, have a particular interest in. This might be doctors who are prescribing for something like pediatric epilepsy or multiple sclerosis. But the vast majority of the medicinal cannabis scripts that we see now are obtained through what's known as the Special Access Scheme, or the SAS, which is a scheme available for supplying unapproved medications to a particular patient for a particular reason. SASB is the way that the vast bulk of this medicinal cannabis is prescribed. And as I said, Queensland provides almost half of the SASB prescriptions for medicinal cannabis. It comes in a variety of forms, sort of flows or flowers and buds. So these are basically just the flower heads of the plant grown in a certified way. You can also formulate it into oils, some liquid capsules as well, some sprays that you spray in the mouth. Less commonly, you might have some patches and gels. They're more so used in clinical trials rather than typical clinical practice. It's usually more those higher methods up that list there that are used. Important to note that just smoking medicinal cannabis through a joint or a bong is not therapeutic, is not judged to be a therapeutic use of medicinal cannabis. It's this distinction that we draw between medicinal cannabis and recreational cannabis, which is important, of course, but it is, at the end of the day, it is the same drug, basically. So I think the last slide on what medicinal cannabis is just coming back around to where we started with THC and CBD, because these are the typical cannabinoids used in medicinal cannabis. THC is responsible for some of the therapeutic effects. It's thought to reduce nausea and vomiting, might help with pain and muscular spasms as well. CBD is also used sometimes in the management of some types of seizures and pain. It might have some impacts on psychological ill health as well, which I'll talk about a little bit more in a minute. This always raises some eyebrows because there's often this sort of question about the role that cannabis might have in contributing to some psychological symptoms. And there is absolutely a balance and an issue there. But again, if we can just hold off that for a second, because I'm going to talk a little bit about prescription for psychological conditions in a bit. Actually, no, I'm sorry, change your plans. Let's do it now while we're talking about it. So THC, the high component, can result in psychosis, paranoia, anxiety, a bunch of those other symptoms as well. And there is evidence that chronic cannabis use during adolescence can be associated with the later development of schizophrenia. Whether that's a direct causal relationship or there's other factors involved, we don't know for sure. CBD, on the other hand, doesn't seem to be associated with these types of adverse effects, and there are actually some suggestions that it might positively impact some of those symptoms, but the evidence is pretty scant. And as I said before, I'll come back and talk about that in a little bit when I'm talking about how it's used in prescription for pain and psychological ill health at the moment. So what is it used for? The most important thing that everyone, including people prescribing medicinal cannabis, should realize and understand is that it is not the recommended first-line treatment for any condition. It really should only be being thought of as an alternative when other more typical or traditional treatments, which have got a stronger evidence base, have not been successful. Doctors are supposed to consider this in detail and actually explain what has been tried, how long it's been tried, and why it hasn't been worked before they can apply for access through this pathway to prescribe medicinal cannabis. I think it's fair to say that it is questionable at best how rigorously this is sometimes done, just when we think about the sheer number of prescriptions being made. And you have to question how much inquiry into past treatment and how many alternate traditional treatments have actually been trialed on patients before they're being prescribed medicinal cannabis. Um, the other thing that I've set up here is that apart from a few very specific reasons for using it, which I'll discuss on the next slide, there is very limited evidence for other conditions. A person with musculoskeletal pain, for example, shouldn't be prescribed medicinal cannabis as early or an initial treatment strategy. Um, None of this is to say that medicinal cannabis does not work. I've spent a fair bit of time before telling you that there is a potential mechanism for these agents to work via the endocannabinoid system. Research and testing is ongoing, and there are some areas in which we know that it can be a useful adjuvant agent. But at this stage, the evidence for a lot of the things that it's used a lot more commonly for is very limited. The last thing I want to say on this slide before I move on is that anyone who is being prescribed medicinal cannabis and their doctor needs to be thinking about the importance of having an exit strategy as well. So, what that means is if the medication is not significantly helping, it's not reaching treatment goals like improving function, then there should be a plan for discontinuing it, which again, I'm not sure is always in place. So, this slide just goes through what the evidence does tend to support the use of medicinal cannabis for. There is evidence, and it's been around for a long time, that in some types of childhood epilepsies, types of medicinal cannabis can be very useful. Chemotherapy-induced nausea and vomiting. There is again some evidence that medicinal cannabis products can be about as effective as other prescription medications here. A lot of that work was old, and so whether they're as effective as the new drugs for nausea and vomiting is perhaps a little bit more questionable, but it is another recognized use. It may also help in multiple sclerosis. Some symptoms like pain, sort of particularly neuropathic pain due to nerve dysfunction and maybe muscle spasm as well. There may be some effectiveness there. When we come down to chronic pain in general, however, this is a little bit more complicated. Again, there is some evidence that in chronic neuropathic pain, so again, that pain that is coming from dysfunction in nerves, there may be some evidence for it as being as effective as some other agents used. But for just more typical chronic musculoskeletal pain, like pain from arthritis or tendinopathy or something like that, there is very, very limited evidence. It is sometimes used in palliative care, both to impact the chemotherapy side effects, pain, and sometimes even increasing appetite a bit as well. Just to be perfectly clear, though, there's no suggestion that there is any anti-cancer property to medicinal cannabis. It's just for symptom control. So these are the things that we've known for quite some time that there is a bit of evidence for the use of this agent for. But what is it actually used for? This is some recent data for the indications for those SASB approvals that I mentioned to you before. So this is where the bulk of the prescriptions are coming from. So the vast bulk of these prescriptions are for non-specific chronic pain and for anxiety. These are not indications for which there has been a long period of history of use and a good stack of evidence behind. So this is the reality of what it's being used for. So let's talk a little bit about chronic pain. This is one of the commonest reasons that patients are started on medicinal cannabis. As I said on the previous slide, there is very limited evidence to support the effectiveness of medicinal cannabis for chronic musculoskeletal pain, like those from arthritis, other constitutional degenerative conditions. Some evidence for use in neuropathic pain as well, but it is still limited. Evidence suggests that it can be effective for neuropathic pain. There have been some controlled trials that have shown some improvements there, but there's a relatively small number of trials. There's different types of cannabis preparations used as well. So there's still questions as to how effective it is. We should be really careful as medical professionals here if we're considering starting a person with chronic non-cancer pain on any type of analgesia, apart from simple paracetamol or anti-inflammatories, because we might be starting a patient on something that they might end up taking for long periods and are likely to have adverse effects. Remember, we talked about the importance of an exit strategy before. I very commonly see a person with a chronic pain condition who's been taking medicinal cannabis for an extended period, but they've still got chronic pain. Despite taking medicinal cannabis, they still haven't been able to increase their level of function. So they haven't improved from where they were when they started taking it, but now they're using medicinal cannabis and are at risk of some form of dependence. Like there has actually recently been a fairly large study done looking at the prevalence of sort of cannabis use disorder or cannabis dependence, if you like, in people who are prescribed with medicinal cannabis. And this sort of reviewed about 10 different studies and found that about 1 in 4 people using cannabis for medicinal reasons kind of met the criteria for a cannabis use disorder, which is pretty, concerning, really. Now, it may well be the case that many of these people had a cannabis use disorder in the past and are now using medicinal cannabis as a way to get their cannabis legally, as opposed to buying it from a dealer. But it just highlights some of the problems that we have here. Now, I do want to really quickly jump in here and add that these problems that I'm talking about are obviously not just the case for medicinal cannabis. All medications have adverse effects. And in the space of pain relief for chronic pain, we have all heard about the problems of dependence on strong opioid medications. Now, medicinal cannabis sometimes gets suggested to be a safer medication than being on strong opiate analgesia, and there may well be some truth in that, but there are still some significant risks of developing dependence from medicinal cannabis. And personally, I think the question shouldn't be, well, it's better that they're on long-term medicinal cannabis than long-term opiates. I think we should be comparing the use of medicinal cannabis or opiates to the actual best evidence-based approach for chronic pain, which is that multidisciplinary biopsychosocial approach for managing chronic pain, rather than using either opioids or medicinal cannabis. But that's probably a little bit me on my high horse at the moment. So let's talk about the use in psychological ill health, quick talk on adverse effects, and then we will get on to talking about some relevant stuff for workplace health and safety. So I think I've actually pretty much covered all of this before. There's this balance or apparent contradiction whereby cannabis is associated with adverse mental health outcomes. That is probably more so related to THC than CBD. And there are some smaller trials which suggest that CBD-only preparations might show some reduction in anxiety. Again, it's not widely shown at this stage, but there is some evidence out there. And yeah, I think that's probably about all I want to say there because I've said pretty much all of the other stuff before. So adverse effects, last sort of clinical slide before we talk about some workplace stuff. So in general, any type of medicinal cannabis can result in fatigue and sedation. It often is reported to result in some dizziness and nausea and vomiting. It can increase or decrease the appetite, interestingly, and result in a dry mouth and diarrhea. So that's kind of any of them can cause that. If we look more so at the products that are high in THC, this is where we start to get some of the more what's the word? Some of the more psychoactive type effects. So feeling high, but also just dissatisfaction, confusion, higher doses, hallucinations, paranoid delusions. I mean, it is, remember, using THC containing medicinal cannabis is using exactly the same thing as if you were smoking recreational cannabis. Broadly speaking, the side effects of the CBD dominant products are less than those for the high THC products. But even the CBD ones can result in some fatigue and sedation and other potentially relevant side effects from a work perspective, like we will talk about in a minute. So, what about some of the legal issues surrounding medicinal cannabis? So, in Queensland, that Medicines and Poisons Act, that is the legislation in Queensland that governs all prescribing and dispensing of medications. I have already talked a bit about the need to get special permission to prescribe medicinal cannabis, so probably don't need to revisit that. I've talked about, I think I did mention, but we've got both the authorised prescriber scheme and the special access schemes. And it's again the special access scheme B is where most of the prescriptions are. I'm going to talk about laws with respect to driving on the next page. One other thing that I will just mention here, because it sometimes does get asked, we sometimes hear about different schedules of medications. You sometimes hear about Schedule 3, Schedule 4, Schedule 8 medications. These refer to different categorizations of prescription medications and the sort of regulations and rules there are around prescribing them. Schedule 8 medications are what would generally be considered higher risk, potentially highly addictive, dangerous medications like strong opiate analgesics, and THC containing medicinal cannabis comes in that Schedule 8. You need a special type of prescription from a doctor for those. Schedule 4 medications, a lot of CBD preparations are Schedule 4 medications, which again need to be prescribed by a medical practitioner, but don't have quite the same degree of restrictions and rules around them as the THC containing Schedule 8s. You may have heard about this idea in the past of CBD that you could just buy over the counter at the chemist. Now, this is legally possible, but not practically possible at the moment. It is true that a few years ago, um, an exception was made for CBD preparations that can prove that they have less than a certain amount of other substances in them, could be sold as Schedule 3 medications, which are medications that you have to go to the chemist to buy, and you have to talk to the pharmacist about, but you don't need a medical practitioner's prescription for. So there was an exception made that if you could sort of show to the TGA that you had a CBD only preparation that met their requirements, it could be purchased over the counter at a chemist. But despite that exception being made, no company or organisation has actually submitted a CBD preparation that meets those requirements yet. So it all does still have to be prescribed at the moment. Okay, so for the second half, let's move on to talk about driving. Now, I have said driving laws in Queensland here. So the relevant laws here, we've got the Transport Operations or Road Use Act. This basically tells us that it is illegal to drive if medicinal cannabis product containing THC is in your system. This is an absolute. It's a zero tolerance. It's what you'd call a summary offence. You just have to have done it. It doesn't matter if you knew you did it or you meant to do it. Doesn't matter if it's prescribed or recreational. Again, the substance that you're taking is the same thing. It doesn't matter whether you or someone else think you are impaired or unimpaired. It is flat out illegal to drive with if any THC is detected in your system. So just following up on this a little bit more, the reason for this is that there is research that shows cognitive and psychomotor impairments that degrade the ability to drive safely. And these can begin at quite low doses of THC. They're very individualized. So different individuals taking the same medicinal cannabis product, or for that matter, smoking the same number of bongs of substance purchased from the same dealer will have differing degrees of impairment. But again, it's not about impairment, it's about the presence of the substance. So a person who is being prescribed THC containing medicinal cannabis has to be advised not to drive or operate machinery. In terms of CBD only preparations, as I said before, they don't result in those same concerning high or psychoactive type effects. So there is not a law to say that you cannot drive if you're taking CBD only preparations. But there are a couple of little caveats just to remember there. CBD can cause drowsiness and fatigue, just like a multitude of other medications as well. So there should be the general idea if you're prescribed this, don't drive if you're feeling drowsy. There is also the possibility, because a lot of these products are not particularly well regulated, that so-called CBD only products could be contaminated with with small amounts of THC. Probably not going to be enough to flick over a positive roadside drug test, but it is a possibility. If there are some people dialing in from other states, or if you have read in the news, you have probably heard about pushes to loosen these driving laws a little bit, and there have been some legislative changes in Victoria and Tasmania. It's important to note that in both of those jurisdictions, however, it remains illegal to drive with any THC in your system. What the situation in Victoria is that a magistrate has the discretion, because the matter you'll still be charged and the matter will still go to court, but a magistrate has the discretion to decide whether or not they're going to cancel your license if you have a valid prescription for medicinal cannabis, and if you have been able to convince the officers and other people that you were not impaired. So that's kind of the qualified defence there. Again, Tasmanian law now provides a medical defence for driving with THC in your bodily fluids if the cannabis has been prescribed and obtained in conjunction with their relevant Medications Act. It's called the Poisons Act in Tasmania. But again, you have to be able to show that you're not impaired. I'm not quite sure how you show that yet. And again, it's only a qualified defence. If you have an organisation that works across multiple states, you need to feel that just because something is okay in one state doesn't necessarily mean it's going to be okay across different states as well. What about driving and work? So, taking one step back before I go to what's on this slide, driving for work can take many forms. You might drive as the predominant form of your work if you are a truck driver, for example. That would make you a commercial driver. If you just drive in the course of your work to and from clients and you're just driving like a car or another light vehicle, that doesn't make you a commercial driver. But, as an employer who has someone driving for work for them, there are still responsibilities to make sure that that individual can safely drive. So it's really important that organisations have closely considered and individually assessed the risk of individuals driving for work if they are taking any form of medicinal cannabis. I mean, I would add to that, or any other potential prescription medication as well. This flags to the importance of developing and instituting policies in this regard, ideally as part of an existing alcohol and other drugs policy. So you've got to consider both the legal requirements and medical guidance when you're thinking about these policies here. As I said, legally is actually relatively simple. You cannot be driving if you are taking THC containing medicinal cannabis. If you've got a truck driver who reports to you that they're taking CBD only medicinal cannabis, then you've kind of got to more individually assess this. And this is often a case where it's recommended if your organisation has a medical review officer as part of their AOD policy program, or this is the situation where occupational physicians sometimes get asked to get involved as well. A common question that is asked by organisations, patients, and everyone is, how long after taking medicinal cannabis can you drive? And there's no simple answer to this. I'm just going to go back to what I said before. Legally, it's very simple. If you are stopped and you have any THC in your system, you have committed an offence. It does not matter how long ago you smoked or used medicinal cannabis. Doesn't matter if your doctor or I or your employer told you you're okay to be driving. You have committed an offence. That's an individual responsibility. The reason that I would never be advising someone that you can drive after X number of days is that the duration of time it takes to clear THC is highly, highly variable. It depends upon how long a person's been taking. It depends a lot on individual metabolism factors and things as well. It can take days or weeks for THC to fully flush out of your system. As you may well be aware, if you've had drug and alcohol programs where a long-term user of cannabis has tested positive and you've put them on some kind of program of increased testing to make sure that they're not still using, it can take a very, very long time for that cannabis to become non-detectable. Um, so yeah, that's probably about all that I wanted to say about driving there. What about safety critical workers? So, as a refresher, reminder, safety critical work is generally defined as tasks where a person's performance error, so either an action or an inaction on their part, might result in a serious incident, injury, death to themselves or others, or to the environment. Now, these roles, they by definition require a high degree of judgment, attention, and medical or physical fitness because errors can have severe consequences. Thinking about the potential effects of particularly THC containing medicinal cannabis, it's pretty easy to see that these two things are not compatible. A lot of safety critical workers have well-defined medical standards, so heavy vehicle drivers, train drivers, airline pilots, seafarers. There's clear rules there that are going to preclude the use of medicinal cannabis if you're performing this type of work. But there's a lot of other work that you as an organisation may um, risk assess to be safety critical, for which there isn't sort of external external legislative medical guidelines that you can fall back on. These are situations whereby you as an organisation, you need to individually risk assess that task and reflect in your organisational policies why an individual cannot be using THC containing medicinal cannabis. It really is beholden on the organisation, if you have people performing safety critical tasks, to have a comprehensive fitness for duty policy, not just about medicinal cannabis, about any medical conditions which might impact an individual's ability to perform these safety critical tasks. And any such policy should include medications which can impact attention, cognition, or concentration, like medicinal cannabis. Um, the other thing I was going to say about safety critical workers here is, what am I saying here? My apologies. I think I've sort of I got too talky on the last slide, and I think I've sort of said most of the stuff on this slide in the last slide when I was talking. What I'm just sort of saying there is that, yes, obviously anything with THC is not compatible with safety critical work. I've mentioned the idea of quality sensitive work up there as well. Quality sensitive work is a bit of a different notion. It's work where if a person stuffs up, they're not going to cause a crash or hurt someone. But if they sort of make a critical mistake that might impact your business or your reputation, we sometimes sort of describe this as quality sensitive work. And that is, another perfectly valid rationale why you may have a policy about THC containing medicinal cannabis in your work, even if your workplace is not what you might traditionally consider to be like a safety critical or hazardous work environment. I have mentioned a couple of times with CBD that while a lot of those, flashing, red flag flashing concerns about THC are not there, there are still potential adverse effects which can affect safety and quality, but it's unlikely to be a situation where you're going to have an overarching policy that says CBD use is incompatible with work in my organisation. The key thing here, as I've said in the last point here, is that decisions that you take need to be backed by your AOD and fitness to work policies, which need to be understood and communicated to your workforce. What about testing and policy? Now, we've touched on this a little bit, so let's spend a little bit of time talking about this. Now, it is increasingly common for organisations to have detailed policies on alcohol and other drugs because of how they may impact safety and performance at work. Many such policies include some form of alcohol and other drug testing. It might be done randomly. It may be done in a triggered or a for cause matter, such as if a person was involved in an incident or if there have been concerns about how they've appeared when they turn up to work, or if there have been other near misses. Um, Cannabis is one of the typical classes of drugs tested for in pretty much all drug testing programs. So there's a bit of confusion here about, how does sort of the legalization of medicinal cannabis impact this? So this is really where your AOD policy becomes critical. Just because medicinal cannabis is now legal, it doesn't mean that you either have to or should allow a person who is taking THC containing medicinal cannabis to perform hazardous or quality sensitive or safety critical tasks. It needs to be clearly set out what your organisation's expectations are, how they're justified, how the testing will occur, and what the consequences are. There should also be sort of in there about what you're expecting employees to report or disclose to you about their medication use and how such disclosures are going to be kept private. Very important, as I've said in the lower part of this slide here, to remember that with all AOD testing, sorry, I didn't say for all AOD testing because alcohol is something where we do have some data for impairment based on different levels. But for all other drugs that we do drug testing for, we are testing for the presence of a substance. We are not testing to say this test shows that you are impaired from the substance. So that's what your policies need to reflect. We are testing for presence, not impairment. Policies need to reflect that that is what is not allowed and that has been communicated to employees and why that is the case. There is some recent case law on this, which I'll talk about in a couple of slides' time. So just a couple of other principles of testing here. So point of collection testing, like oral fluid or urine testing, it's designed to test for THC. It doesn't really test for CBD. I'm not sure if there are any if there is reliable testing for CBD at the moment. I mean, if anyone's interested, ANZOM, our sort of society for typically medical practitioners, but also other individuals interested in occupational health and safety, we are having a meeting in a couple of weeks' time. I believe it's Thursday, the 27th of November, whatever, basically next Thursday, where we've got Charlie Appleton, one of the chemical pathologists at QML, who is going to be talking about some contemporary issues in AOD testing. It would be a really good talk if you just sort of Google the ANZOM meeting there. That would be, if anyone's interested there. So if the preparation that a person is taking has got a significant amount of THC in it, they're probably going to test positive at point of collection testing, which will then go off to the lab. If it's predominantly CBD, point of collection testing will likely be negative. Another question that we often get, can you tell the difference between prescription and non-prescription cannabis? And the answer to that is no. Drug testing tests for a particular compound. It tests for THC. THC is found in both recreational and medicinal cannabis. You cannot determine, well, to any way that I'm aware of anyway, definitively based on drug testing, that cannabis that you're detecting is medicinal as opposed to recreational. What have I said here? So yes, you will get a positive result if the THC in the person's system is above the cutoff. Urine testing is much more likely to pick up THC, be it from medicinal cannabis or recreational cannabis, than oral fluid testing is. This is because THC is not secreted very well or much into saliva. Some other drugs are secreted into saliva and are more likely to be picked up on oral fluid testing, but THC is not one. Again, that's the same for both recreational or medicinal THC. You will tend to only pick it up on oral fluid testing if there's been quite recent use of the drug and some of the residue of the drug is still hanging around in the person's mouth to be detected. But simple things like brushing your teeth or drinking can remove this residue. So oral fluid testing is very, poor at picking up THC. That's not just the case. This is not a unique thing for medicinal cannabis. Anyone who has an AOD program and has spoken with an MRO will know that it's not a good testing methodology for picking up cannabis. So I've said here you cannot rely on AOD testing to detect whether you're using medicinal or recreational cannabis. I'm just reiterating some take-home messages for drug and alcohol testing on this slide. We are testing for presence, not for impairment. with if there are concerns about impairment, you have to be looking at other things. You have to be looking at, has there been a decline in work performance? Is the person frequently arriving late? Have there been safety lapses or near misses, changes in behavior? Have other people noticed concerns? In these situations, this is where you would often be wanting to seek some expert occupational medical advice. The biggest thing is the importance of having a comprehensive and defensible AOD policy and fitness to work policies which you work within. It's also recommended that you have a medical review officer involved in the program. As I said before, there's been some recent case law around AOD testing and policy in medicinal cannabis. If you look up Gauci versus DP World Brisbane just from last year, this was a case where a stevedore argued that they'd been unfairly dismissed due to a positive test for medicinal cannabis. What was found, just to summarize here, is that the dismissal wasn't actually because the individual had tested positive. The dismissal was because the individual had not disclosed to their employer that they were using THC containing medicinal cannabis, and that was accepted to have been part of the AOD policy. And because the policy was sound and the individual hadn't followed the policy, it was the Fair Work Commission upheld the decision to terminate the employee. That's a really broad, non-legal expert overview of that case. I haven't got time to go into it in detail, but advise you maybe to have a bit of a read of that. It is an interesting read to talk about it. Second last slide, don't forget that medicinal cannabis is generally prescribed for some medical condition. Whether it is the most appropriate treatment for that condition is by the by, but don't forget the medical condition that the cannabis was being prescribed for. If an individual has got chronic pain, or if they've got epilepsy or multiple sclerosis or a malignancy, or even some of these more, recent, more common indications like, chronic non-specific pain or anxiety or trouble sleeping, all of these things can have fitness to work implications as well. They may, in fact, be more potentially problematic than the use of medicinal cannabis. So this is again a situation where, it's important that you have a fitness for duty policy that links up with your AOD policy and have pathways in place for being able to seek medical advice on a person's fitness for work if required. So just to sort of summarize, just if there was a broad suite of obligations that I think employers and organizations need to be mindful of in the context of medicinal cannabis, I'd probably summarize some of the key things as follows. So as you know, you've got that overarching duty of care under the Work Health and Safety Act in Queensland, or a very similarly named legislation in other states, whereby you as a PCBU must provide a safe system of work. And you need to do that by developing relevant policies. When we think about these policies, make sure, review your AOD policies, make sure they can capture the implications of medicinal cannabis. One of the things that I do sometimes say to organizations is that in the sense of it being a medication that you need to deal with in the workplace, it's not actually that different fundamentally to any other medication. A person who is taking high dose opiate analgesia or another medication that's got bad side effects, you should have a policy whereby a person who is taking a medication that has any side effects that might impact safety at work needs to sort of, report that and show that they are actually fit to attend work. There are some unique things about medicinal cannabis because of the effects that it has, but just the general principle that if you have an employee taking a medication that might impact their fitness for work, then that is something that they should be disclosing or discussing. That is a more general idea of something that should be in a policy. You need to, if you're going to have a policy that talks about these types of disclosures, though, you need to be making sure that you have strong rules around privacy and confidentiality for these types of matters. All medical information, of course, must be handled confidentially and in accordance with relevant privacy laws here. As part of your policies, you need policies around fitness for duty. You might need to risk assess your roles, work out, do you have safety critical or other hazardous type of roles? If we do, how does that feed into our fitness for duty policy and our AOD policy? Following on from that will then become the question of, okay, if the system works and we do identify, someone discloses to us or we find out through AOD testing that they are using medicinal cannabis, we know that we can't put them back to doing safety critical work. What does our policy say about reasonable adjustments? As I'm sure you know, you do need to consider requests for reasonable adjustments in the workplace. You are not obliged to always provide them, but you need to be able to justify why you do or you don't if you're going to not. So, you may be faced with a situation where a person you find out that they are using medicinal cannabis, and you need to be thinking about, okay, what else can I get them to do at work? You need to have clear policies around driving at work, as I said before. And I mean, training and educating managers and staff about all of these things is important. With any of these policies, consultation, consultation, consultation is always key if the policy is going to be upheld and considered valid. So you need to have that consultation and education with both your staff and your managers as well. And I think that's probably enough of me talking at you. So thank you very much for your time. And I'm happy to have a look at if anyone's got any comments or questions just for the last sort of, I think we've got about 5, 7 minutes or so to go.
Thank you, Andrew. I do have some questions that have come through. The first one is from Catherine. She would like to know, what is the appropriateness of taking medicinal cannabis for someone who has a known opioid addiction?
So, I mean, look, this is, I guess, an individual, like this is, I suppose, more an individual clinical or medical question. So I can't give you sort of a specific answer about a given case here. There, as I said, there are schools of thought that if a person can come off opioids with medicinal cannabis, maybe that's better. I would think that the risks of developing a secondary dependence on the cannabis would be fairly high in an individual who has had dependency problems before. But I mean, I would really sort of leave the answer to that type of question to probably a treating specialist or pain specialist involved in the individual's care.
Thank you. The next one is from Diane. Does a negative saliva test demonstrate no impairment, even when urine test demonstrates non-negative result?
So the first general principle, again, coming back to the general principle, no drug testing tells us anything about impairment. Drug testing only tells us about the presence of a substance and use. In the context of THC, a negative oral fluid test doesn't tell us very much at all because THC is very poorly secreted in saliva. If there is a positive oral fluid test for THC, it tells us that it is likely that THC has been used relatively recently because, as I said, the only way it tends to get picked up is if there's still residue of it in the mouth from having smoked it or ingested it some other way. If there is a positive urine test for THC, that again tells us that a person has used THC. It doesn't tell us when they've used it or how much they've used it, but it confirms that they have used it sometime relatively recently. But again, it still doesn't tell us anything about impairment.
Thank you. And I do have the last question at the moment is from Nicole. She says, I've seen where a person reports taking medical cannabis for the purpose of pain management and continued to maintain prescriptions for opiates. Is this typical, or would you expect to see the opiate prescription wean when the CPD is introduced in general terms?
Look, I mean, clinically, I would like to see both of those things weaned, but again, it's a little bit Commenting on individual cases is fraught here because I don't know the full background. Broadly speaking, if the aim of getting onto medicinal cannabis was to get off opioids, then yes, then ideally you would want to see reduction in the opioids in conjunction with the addition of the medicinal cannabis. Sometimes people who are using opiates for a long period of time and are still having pain will have a doctor prescribe medicinal cannabis in addition to the opioids. I think that adds like a whole bunch of potential risky side effects, but it's done sometimes. So, I mean, the short answer is if the aim of the medicinal cannabis was to get off the opioids, then yes, ideally you'd be seeing a reduction in the opioids as well. But there's individual clinical factors that might be at play as well.
Thank you very much. I do have a new question from David. I'm aware that some prescriptions and product bottles come with a warning from the Pharmaceutical Society of Australia if they contain, in brackets, THC, that you are not to drive a motor vehicle or operate machinery.
Yep.
In my experience, persons taking prescribed cannabis which contains THC are ignoring the warning labels and are not aware that it is illegal to drive motor vehicles in Queensland with THC in your system. The question is, do you have information we can pass on to the workforce to educate them on this?
Yeah, so I see that quite a lot as well. Um, Whether this relates to the doctor who is prescribing the agent not spending enough time and making it clear to the individual that they cannot drive, that is one possibility, which as a doctor I would hope is not happening. I would very much hope that my colleagues are making that very clear to everyone, but I suspect that that sometimes does not always happen. There are other potential explanations for this as well, though. I think sometimes patients can hear what they want to hear, perhaps, rather than what they are told, or can, hear parts of what they are told. There may be situations where there is willful ignoring of that advice. There may also be a genuine misunderstanding where if they are just told you can't drive while you are using this agent, they may interpret that as saying, oh, that's okay. I'll just take it at night and I won't take it during the day and I'll drive during the day. That person is absolutely going to be positive if they are stopped by the police. But if the doctor hasn't actually gone and fully explained that you actually have to stop driving until you have stopped using it and until you stop using it for a long period of time, it's potentially up to that degree of interpretation. I frequently have this discussion with people that I see, and they say that that's not what they have been told. And as I said, whether that genuinely is not what they've been told, or just that they're either consciously or subconsciously not hearing or listening to what they're told, I don't know. In terms of what you can, what you can sort of show, if you just sort of do a bit of a basic Google search about medicinal cannabis and driving in Queensland, you should get up some information from, let me just do this on the side here. You can get some information from authoritative bodies in Queensland that you can sort of distribute in your workplace. Let me just do a quick. So yeah, you can get the basically if the first result that I get for medicinal cannabis and driving in Queensland is a site from the Queensland government site from sort of partially from Transport and Main Roads, has got some very clear information there that you can sort of describe. Again, Department of Transport and Main Roads has got some information up there as well. So there are some authoritative sites that you could direct people to or print out.
Oh, thank you. I've got quite a few questions coming through now. We'll just try and get through as many as you have time for, Dr. Lingwood. Jen has asked, how would you approach consultation with a doctor on the topic of management of an employee affected by prescription in terms of performance, in brackets, to understand treatment, end of brackets, if what they are treated for is not related to a workplace injury?
Okay, so I'm just trying to unpack that a little bit. How I'm interpreting this is that there seems to be a couple of components to this. So the issue of a non-workplace versus a workplace injury. So that's not going to change the risk assessment in terms of assessing the risk from the medical condition and the risk from the treatment. If I am referred an individual for a fitness for duty type assessment in a situation like this, it doesn't make a difference to me whether the injury is work related or not work related. It may make a difference from your organisation in a policy perspective in terms of whether or not you are going to accommodate alternate duties for a work related versus a non work related injury. But the distinction between work related and non work related here, to me, is less important from the medical risk assessment perspective. I think the earlier parts of that question were about, how would you approach this with an individual's doctor? Now, if you're talking about doing this as like a formal fitness for duty assessment with an occupational physician, what you would basically do is you would just explain all of your concerns to the occupational physician, and they would sort of, do a lot of the risk assessment and recommendation for you. It can be a little bit trickier in terms of trying to seek advice from an individual's treating practitioner because the amount of advice that you will get from them can be very variable, depending upon what the doctor's comfortable to share, what the individual has authorized the doctor to share. I think one of the sort of simplest questions that you can reasonably ask is because you don't really have a right to ask, why is the person taking this? What's the medical condition that they're taking? What you can absolutely ask, though, is for the individual to demonstrate that a medical condition or treatment is not impacting their ability at work. So I would probably be starting with really basic questions. So if a person has disclosed to you they're taking medicinal cannabis, I would be sort of asking the treating doctor, this individual's disclosed that they are taking medicinal cannabis. These are the things that they need to do at work. Can you give us your medical opinion as to whether or not they can safely do this whilst using medicinal cannabis? So you're asking sort of the doctor to basically, confirm in writing for you that they're aware that the person's taking medicinal cannabis, they're aware of the tasks that are involved, and if they are comfortable in signing off the person off for doing that. If you're still concerned, then really the next step is seeking specialist occupational medical advice. I hope that's answered that question. I'm not sure if I fully followed the question, but that's sort of how I've interpreted it.
No, I think you covered everything there. I've got three questions. I think we won't have any more time for any more, sorry. But this is from Sean. Medicinal cannabis is becoming more prevalent within the workplace, increasing the number of cases of staff seeking to 100% work from home. What information do you recommend workplaces consider when reviewing such cases, and is there anything workplaces should avoid?
Okay, so I'm sort of going down two paths here. Like if the request to work from home relates to the fact that the individual is not able to drive into work, then just that side of things, that really is not so much a medical issue. That's more an HR issue in terms of whether or not you as an organization are happy to sign off on a person working from home. An individual can still catch, if it's available where they're working, they can still catch public transport to and from work. So there are other transport options. If the person is saying that they are unable to get into the office either because of the effects of the medication, sorry, either the effects of the medical condition that they have or the effects of the substance that they are taking, then that would raise a flag to me as to whether or not they are fit to work in general. So I think this is probably a situation where I would be very tempted to recommend seeking formal occupational, medical, or fitness for duty advice, probably need to first clarify from the individual the exact or specific reason that they are requesting to work from home. You could again trial some of that basic advice from the GP initially, but this is probably going to sort of cross both occupational medicine and HR policies, I think.
Linda just quickly asks if CBD oil in pain management would work if used as a topical ointment.
Um, the short answer to that is it depends. Maybe, I don't know. I mean, the trials and evidence for most of these agents are limited. They are emerging. I mean, in a few years' time, we may be saying, yes, they are great for this, that. At the moment, the evidence for, topical CBD is not widespread by any means. That's not to say people don't find it helps. There are people that I have seen who have said that they do notice a benefit from using various preparations of CBD. But yeah, it's not really an answer that, sorry, a question that I can give a definite medical answer to.
Thank you. Last question from Matt. Information to the GPs too, given there are some GPs prescribing and then following it up with a letter to the insurer stating words to the effect that they're not impaired. Employees need to drive to get to work. Then we get a TI certificate. I'm assuming that's total incapacity. How
Yeah.
do we challenge that?
Okay, so
Oh,
that is.
sorry, Andrew. And Matt's
uh,
just added in further, it's the treatment rather than the condition causing the
Yeah.
TI.
Yeah. Okay. So I guess so like a couple of things here. Very rarely is medicinal cannabis covered by Work Cover Queensland. I think I mean, I may be wrong there, but I still don't. I think that it is very rarely approved. I mean, that said, what my pushback, if you like, to that would be is that sure, a person using THC containing medicinal cannabis cannot drive, but what you should be going back via the insurer to ask the question is, a person being unable to drive does not mean they are totally incapacitated for all forms of work. If a person had previously had capacity to perform alternate duties before they were prescribed medicinal cannabis, they retain the capacity to perform the same duties that they were previously performing. It's just that they can't drive to and from work. It's then probably going to become a bit of a matter of a negotiation between you as the employer and the insurer as well about how transport's going to be sorted out. Is the insurer going to cover Uber vouchers? Is it reasonable to tell the person they need to catch a bus or public transport? Again, these aren't really medical questions, but to me, what I would be doing is I'd be going back to the insurer and getting the insurer to go back to the doctor and point out that this person was previously fit for suitable duties. Just because the treatment has stopped them from driving, it doesn't mean that they are now totally incapacitated for all forms of work. I would say as well, though, where you say that it's the treatment, not the condition causing the incapacity, from like an insurance and medical perspective, there's not really a distinction there at all to me. It all forms part of the condition and the claim, if you like. So if you are recommended a particular treatment for a particular condition that is accepted to be a work-related injury, then the sort of all of the aspects of that treatment are kind of going to come under the umbrella of that claim. But again, it doesn't change the fact that just because you cannot drive does not make you totally incapacitated for all forms of work. It just makes you incapacitated for being able to drive to and from work. And yeah, you need to push back on the insurer to push back on the certifying doctor. Oh, sorry, I'm not sure if anyone's still there.
Sorry, I'm talking away with
Okay.
my mic off.
Oh,
I just wanted to thank you very much. I have got, everyone's had a good afternoon. Thank you very much for your time today, Dr. Lingwood. I've shared the link for the ANZON meeting on the website for the meeting on the 27th of November. It's being held at the Phoenix Occupational Medical Rooms in the city. Register there if you are interested to go to that. And otherwise, thank you very much. This meeting has been recorded and will be available on our website. Please allow up to 3 working days for it to be uploaded. All right. Well, thank you very much, everybody, and have a good day.
thank you.